Hi, my name is Mike Riley, and I'm a professor of facial plastic and reconstructive surgery at Georgetown University Hospital and MedStar Health. Thanks today for joining me for my talk about optimizing the medical management of idiopathic facial palsy. Not the sexiest topic at the AAFPRS meeting, but hopefully one that will be highly impactful and stimulate some thought and future direction. I have no financial disclosures related to this topic. The objectives for this talk, this 10-minute talk, are going to be just to briefly review, evaluate the current standard of care, and then come up with some options for improving. So the pathophysiology of facial palsy is known to be either viral reactivation of the herpes simplex or zoster virus from the geniculate ganglion that travels along the facial nerve, resulting in inflammation of that nerve and sometimes neighboring nerves, or it could be from proliferation of the Borrelia burgdorferi spirochete associated with Lyme disease. When this happens, the nerve gets inflamed. You can see here inside the epineurium, between the perineum and epineurium, is all this inflammatory edema that ultimately causes compression, neuropraxic, and sometimes neurometic injury to the facial nerve. So how do we know the cause? It's called idiopathic. So do we really know that those are the causes? Well, there was a great study done in Japan about 20 years ago that looked at 142 consecutive patients. They did serum and salivary samples on every patient, and they were able to come up with a definitive diagnosis for all 142 patients and divided them into these categories of herpes simplex virus, still taking the primary majority with 58% of the cases. But importantly, this red group here of 25% was herpes zoster synaherpeta, which means that they had all the lab findings suggestive of a zoster reactivation, but without the characteristic vesicular rash, therefore indicating that maybe a much greater portion of the facial nerve inflammation that we see in patients with facial palsy is really due to herpes zoster virus than to herpes simplex virus, or at least a larger degree. 15% of those patients did have classic findings of a vesicular rash, and then and consistent with herpes zoster, Ramsay-Hunt syndrome, and then 2% had Lyme disease. So the current guidelines were published in 2013 by the AAOHNS, and what they honed in on was where the data was, and what they were able to prove was that an H&P was absolutely important. Oral steroids within 72 hours were highly recommended. Eye protection was highly recommended, and that there was reason to reassess for either worsening symptoms, ocular symptoms that were unabating, or persistent symptoms at 3 months. They advised against routine lab work imaging, oral antivirals without steroids, and an ENOG, they said that it was reasonable to consider an oral antiviral within 72 hours, and it was reasonable to consider an ENOG if there was complete facial palsy. They didn't think there was enough information for surgical decompression, physical therapy, or acupuncture to make a recommendation one way or another. So the prednisone recommendation is based off of a couple of large studies. This is one of which was a greater than 800 patient study done in Sweden. And what they showed was that when prednisone was given with Valtrex, but either independently or with Valtrex, there was a much greater likelihood of recovery. In the prednisone plus Valtrex group, with the Sunnybrook score, there were 74% of patients got complete recovery of function when given a 10-day course of steroid taper with a course of Valtrex, a 7-day course of Valtrex, as compared to 71% in the group that only got the steroid. So somewhere between 71 and 74%. Using the House-Brackman, it was a little bit higher, but importantly, what is not often discussed with this data is that the patients, when subdivided by flaccid facial palsy, only 51% of those patients got full recovery with optimal medical management. And that's the same group. They went back and looked at their data a couple of years later, and they were able to separate it by Sunnybrook score at presentation. They found that when you have flaccid facial palsy, you have about 50% chance of recovery, even with optimal medical management. So that's where we are right now. 26% chance of incomplete recovery if you don't, by all comers, and 49% chance of incomplete recovery if you have full flaccid paralysis at the time of onset. So in my opinion, that is not acceptable, and we have to do better or come up with something that we can do to help these patients. So are there predictors of non-recovery? Well, as that study just showed, when the Sunnybrook is low and when there's flaccid facial paralysis, that is a predictor of non-recovery in and of itself. In addition, there have been studies that have shown that the symptom of ear pain, 11 to 17 days, so in that just after the steroid taper is finished, after the onset of the condition, if you're doing a 10-day steroid taper, that those patients in the 11 to 17-day pain group have a significantly worse outcome than those who do not have pain at that time point. And then lastly, there are really good data to indicate that if there is evidence on MRI of inflammation in the nerve at the time of MRI done within the first 3 weeks after the onset of the condition, that also heralds a poor prognostic sign. So what is the evidence for better treatment? Even if we knew which patients weren't going to get recovered, how would we treat them, and what would we do, and what does the data show? Well, there is some evidence. So in 26 patients with traumatic facial palsy, there was a study that showed that patients who underwent a greater duration of systemic steroid treatment for more than 14 days after the onset of their condition had an 11 times, actually 11.5 times greater likelihood of full recovery of their facial nerve as compared to the patients who only had a 7-day treatment course. There's also good information in the ophthalmologic literature indicating that in patients with herpes zoster, herpes simplex ophthalmoplegia, which is, a sister condition to the herpes simplex facial nerve neuropathy, that in those patients, there's actually a duration-dependent relationship between the steroid intake and the steroid treatment and the outcomes in those patients and the likelihood of full recovery of motor function of their extraocular muscles. So fairly reasonable to extrapolate that there may be some similar expectation with facial nerve and facial muscle recovery. Is there evidence for a longer antiviral regimen? Well, there are a couple of good studies showing that a longer duration of antivirals given for herpes zoster actually leads to less pain at specific time points after the onset of the condition. In this study in the New England Journal in 2000, they randomized patients to either a 7-day or 21-day course of antivirals, and the people getting a longer course of antivirals had less pain at the 14, 21, and 28-day time points. Similarly, simian zoster animal studies have shown that there are varicella zoster specific T cells active in sacrificed nerves in animals who are sacrificed 3 months after the onset of the reactivation. So clearly this virus is still actively engaged in the body 3 months after the onset of the initial clinical sign. And then lastly, the ophthalmologists have known for more than 20 years that a longer duration of antivirals in treating herpes simplex ophthalmicus, a sister condition to herpes simplex facial neuropathy, leads to better outcomes and specifically in the eye, 45% reduction in recurrent herpes simplex ophthalmicus cases, specifically in stromal keratitis, which is one of their major clinical signs of infection. Is there evidence for calcium channel blockers? Yes, there's mounting evidence that calcium channel blockers, which have long been animal studied, that are helpful in the treatment for nerve recovery following subarachnoid hemorrhage, which is the FDA indication, but also in other neuropathic conditions. So in this meta-analysis from 2019 from Laryngoscope, there was evidence from these 3 different studies that had all studied facial neuropathy following post-surgical intervention that showed a 2.78-fold increased likelihood of recovery to at least a House-Breckman grade 3 when using nimodipine TID in the immediate postoperative period. And most of those studies extended that treatment for about 3 months. Is there evidence for vaccination? There's clearly evidence for vaccination against the shingles virus, the herpes zoster virus. The vaccine is called Shingrix. It's a 2-dose vaccine. It's CDC recommended for anybody ages 50 and older that doesn't have a contraindication. And it's very successful. And so if we're accurate that, like I mentioned earlier, 40% of facial palsy cases there more or less are coming from herpes zoster virus. And we know that the Shingrix vaccine can be, between 90 and 98% effective in preventing the shingles episode, then certainly we're doing our patients and population a favor by advocating for that Shingrix vaccine for anyone who's a candidate to get it. So in conclusion, I think the rate of complete recovery after sudden facial paralysis is unacceptably low. And I think when you look at the data, that's a pretty clear conclusion. It's especially low in those with flaccid facial paralysis. There are some indicators that may be able to help us determine which patients are at the greatest risk of incomplete recovery. And what do we do with that data? And what do we do with all those patients, even if we don't see one of those indicators? Well, there's evidence, as I assembled here, which is spotty, admittedly, but is founded in science and good studies that indicates that in non-Lyme disease associated facial palsy, which really is a different condition, but once Lyme disease is involved, steroids are actually counterproductive. But in non-Lyme disease associated facial palsy, prednisone treatment for 3+ weeks is reasonable. Even transtympanic steroids, if that's a reasonable option for a patient to be given at your institution or location. Valtrex, 1 gram TID for 3 weeks, has been shown to decrease pain at those important time points after the onset, which may indicate the likelihood of recovery. And there's evidence from the ophthalmology literature that suppressing the virus with a low-dose antiviral regimen for a year or long-term treatment afterward or until full recovery are also reasonable to consider. There's evidence that calcium channel blockers improve the likelihood of recovery following a traumatic facial injury, which again, these virally mediated nerve injuries are similar physiologically. And then lastly, there's very strong evidence for that Shingrix vaccine to help those who've had a palsy avoid a recurrent episode, and to help those who've never had one never get one. So with that, here's my algorithm. This, I'm sure, will be able to be paused and reviewed at your leisure. It goes through in detail kind of my thought process, which I hopefully was able to elucidate intelligibly today. And I will look forward to hearing any thoughts and conversations that come from this. Don't hesitate to reach out to me. I would be curious to get your thoughts and insights into how we can work together to make this condition less detrimental to our patients moving forward. So I want to keep all these smiles on my patients' faces that I get when I get to see my beautiful family. And I hope you all get to spend a little more time with your family and see the silver lining of not getting to be with each other in person this year. But looking forward very much to seeing all of your smiles next year. Thank you.